this is Dr. Pruett. Today we're going to be talking about LVADs. We'll go over what it is, who gets it, how to assess these patients, and then common complications to think about. So an LVAD is a mechanical pump that's attached to a failing heart, and essentially what it does is the heart that can't pump enough for itself to perfuse the organs, it's going to do the work of the heart for the heart to make efficient blood flow. So if you remember blood flow through the heart, blood comes back from the body after it's delivered its oxygen through the inferior vena cava, superior vena cava onto the right side of the heart, goes out through the pulmonary arteries to pick up oxygen, comes back through the pulmonary veins into the left atrium, out the left ventricle, out the aorta, and then to the rest of the body. So who needs an LVAD? It's basically patients with heart failure, and there's different stages of heart failure, so technically it's patients with class 4 heart failure, and these are patients who are having symptoms at rest and profound decrease in their lifestyle based on their inability to have good cardiac output. So things that can cause heart failure would be STEMIs. You know that time is muscle. This is what a STEMI looks like. Here you see the big tombstones and the anterior leads here. But more and more people are surviving their heart attacks, and we know that heart attacks is the lack of oxygen delivery to the organs, right? And so if you see this heart here, it's a big anterior STEMI. This is a big scar on the front part of the heart that has been without blood flow for a little while, whereas the rest of the heart looks like it's a nice healthy muscle here. And so as more and more people are surviving their heart attacks, you can imagine if this left ventricle is trying to squeeze blood out to the rest of the body, this healthy muscle back here is going to be a lot stronger and a lot more effective than this scarred down wall here. And so that's going to have a really profound effect on cardiac output. Here's another picture of what a heart attack might look like. This is a septal infarct. Here you have your left ventricle, your right ventricle here, and see how this muscle over here on the left side is compensating for the lack of muscle over here in the septum. And here is a picture of left ventricular hypertrophy. So this is likely a patient who has really poorly controlled blood pressure over a really long period of time. The heart is just a muscle, and just like any muscle, if it's pushing against higher resistance, it's going to get bigger, right? The problem is what happens is the heart doesn't move outward, it moves inward, and so it's going to decrease the amount of area that ventricle can fill and decrease the amount of blood that can be pumped out, so it's going to have a decreased stroke volume compared to a normal left ventricle that you see over here. Cardiomyopathy is another reason for heart failure. This is a big floppy heart. You can just imagine this heart trying to squeeze. It's not going to have a really strong, robust ability to get blood out to the rest of the body where it needs to go. It's just too floppy. And so all of these things can lead to heart failure. It's all about cardiac output and getting blood to where it needs to go. Now, the purpose of an LVAD is to get these patients either to transplant or to recovery. Sometimes, especially with cardiomyopathy, sometimes that gets better, not all the time, but most of the time these patients will need a transplant or some sort of bridge. The other option for an LVAD is just destination. This is a device that's put in their chest just to make them feel better, to pump blood a little bit better, and to give them a little bit longer life and a little bit higher quality of life. If you look at heart disease and stroke statistics for the last couple of years, coronary syndrome, heart attacks, everything is just going up, up, up. And as the population is aging, we're going to see more and more people with heart failure. So already, 92 million Americans have cardiovascular disease, and almost half of those are older than 60. And the population is just going to keep aging and just going to keep getting sicker. If you look, most of the heart failure is concentrated in the southeast United States and in Texas, but we have a fair amount of it here in New Mexico as well. And it's estimated that heart failure is just going to become more prevalent over the years as the population ages and our society continues to have poor control of their risk factors for this disease. Now, the problem is if we know that this disease entity of heart failure is going to continue to increase, if we look at heart transplants over time, they really haven't changed that much over the last 20 years. It's pretty steady at just over 2,000 a year. And so what that's led to is a need for some sort of alternative management strategy for heart failure patients. So why do we care? Well, what that means for us is we're probably, until they figure out a better option, we're going to start seeing more LVADs in the field. If you look at LVADs that have been implanted over between 2006 and 2014, the number is just going up, and it will continue to increase. So the demand for heart transplants is going up, which means the demand for LVADs is going up, and these are going to be more prevalent, so we need to be familiar with them and know how to treat patients that have them. So if we think about how it works, it's essentially just a pretty simple pump that's attached to the left ventricle, which, if you remember, that's the ventricle that squeezes blood out to the rest of the body. It bypasses that aortic valve there and literally sucks blood out of the left ventricle and pumps it out through the aorta. Now, it has different parts that we need to be generally familiar with. You've got the pump that's inside the chest, right? It's battery powered, so there needs to be a power source. This is really important. And that's connected through a line outside the skin into a pack and a controller that's going to do all the functions of the LVAD. And the line that connects them is called the Driveline. So if you look at the Driveline, this is literally the connection from outside the patient's body to inside the patient's heart. There's a huge risk for infection here, and there's a real risk of wear and tear as well. So this can kink, it can have mechanical problems. Patients get an extensive amount of education on how to care for the site, how to keep it clean. You can see here he's got sterile gloves on trying to prevent infection. It really takes meticulous care and a lot of training for patients that have this, and it's absolutely their lifeline. So it connects to a controller, which is going to be a good friend for us because these are pretty fancy and can tell you exactly what's going on with the LVAD. So this is a controller that usually sits on a belt kind of around their waist, and it connects the Driveline and the LVAD to a power source. It operates the pumps, and usually they have different alarms and settings that you can tweak or will tell you what's going on. It also has battery indicators and flow meters as well. So there's different types out there, but each of them have essentially the same stuff. So you'll be able to tell battery, you'll be able to tell flow, and then discern which alarms are going off. There's different types of power options for LVADs. Some of them come with batteries, usually lithium ion is most common. There's rechargeable ones. And then you can also plug them into power, which I highly recommend. If you get them in the back of your ambulance, just plug them in to the wall rather than rely on their batteries. Now the pumps are pretty fascinating, I think. I'm not a physicist, but I think they're pretty cool how they work. Usually what you're going to see now is more of a continuous flow device, which what that means for us is this heart, if you think about our hearts, they're constantly beating, right? You'll have a part where there's beating, and then there's a part where it's relaxing to fill, and then you feel another beat and then relaxing. Well, with a pump, you're not going to feel a pulse. So functionally, these patients are in PEA. And the way the pump works is it's either a rotor or an impeller, and that's going to accelerate blood through the device and get it to the rest of the body. And just like any flow device, flow is going to be dependent on the pump speed or the rotations per minute. So if you think about LVADs, remember our cardiac output equation is heart rate times stroke volume. And so there's certain factors that affect heart rate, right? There's autonomic innervation, whether that's sympathetic or parasympathetic. You're going to have hormones. It's going to be affected by age. We can't change any of these factors for the patient, okay? But if you think about other factors that control cardiac output and heart failure, heart size, fitness, gender, can't change those things either. The one thing we can have effect on is preload, right? And that's going to increase stroke volume, right? If you're putting more volume in the heart, you're going to increase the volume that's being ejected, and that's going to increase cardiac output. And so it's important to note that LVADs are preload dependent. So a lot of times just a little bit of fluid can make a really big difference for these patients. Over the years, LVADs have become more sophisticated as technology gets better and as we get more experience with these devices. First generation was pretty cumbersome and not great. Second generation is still out there, this HeartMate 2, and then now there's HeartMate 3 out on the market now and will become more common as we progress. So the HeartMate 3 is really cool. It's a magnetically levitated rotor, and it basically is frictionless movement of blood flow with really wide passages for blood to get through. There's no mechanical bearings and low shear stress. In the previous versions of LVADs, there was a rotor pump that tend to tended to shear blood vessels and cause a lot of hemolysis. But with this magnetically levitated rotor, we don't get that as much. And it's really cool. If you imagine your left ventricle here, and here's the essence of the LVAD here, there's a rotor that is suspended in space by a magnetic field, and it's just constantly pulsating, and that helps send the blood through, but it's not turning or shearing or causing hemolysis. And if you look at the way that this is designed, is there's not really a place for blood to pool either, so there's less clotting as well. And then it basically takes the blood from the left ventricle, accelerates it through the rotor, and then sends it out to the aorta. Now, this is relatively new, so this is a recent study that was done in the New England Journal of Medicine, and it compared the old flow device, which is the axial flow, which there was a rotor that led to a lot of hemolysis and clotting and other things, but propelled the blood through the LVAD, whereas this magnetically rotated one here. And it was called the Momentum 3 trial, and it compared the two devices. It was about 300 patients, and they looked at them at about 6 months post-implant. And what they found is that the centrifugal device was much better. So there was less evidence of thrombosis, there was fewer strokes that were a result of clotting, fewer infections, and found that this device is actually better. So what do you do when you're called to these patients? Well, you want to begin at the pump and then work towards the patient. So do you see any alarms? How's the power? What does the driveline look like? And do you hear a hum? I would look at that controller device first and see if sometimes it'll just tell you what's wrong, and then your job is done. If it's not being helpful, you want to assess that driveline for infection and then just listen over the chest, and you should be able to hear a hum or a mechanical sound all throughout the chest. If you have decided that all those things are normal and you're not seeing anything wrong, then start to assess your patient. So think about normal patient things. Just because they have a device in their chest doesn't mean that they could have other things going on as well. Now, there is a little bit different approach to assessment of these patients. When you're taking their vital signs, like I said before, realize that they're not going to have a pulse. They're functionally in PEA, so it's going to be really hard to tell anything. What you want to know is, in terms of a pulse, or if there's blood flow being generated, you're just going to listen for that hum. Blood pressure, again, is going to be hard to measure. What you want to get is just a mean arterial pressure, so you can inflate your blood pressure cuff and just use that first number that you hear as blood starts to flow again, and that'll be your map. And also be aware that because of the reduced pulse pressure, it might make it really difficult to get an O2 sat reading. Don't be surprised if that happens. So here's how you take a blood pressure. Just inflate the cuff like normal, and then the first number that you get will be the only number that you get, and just write that down. That'll be your mean arterial pressure. Should be somewhere 60, 65. Now, LVAD patients are going to be really important. This is where your spidey senses come in. Because your vital signs aren't going to be as reliable as normal, you're going to really depend on what your patient looks like and what they're telling you. So mental status and skin color are going to be huge in determining how sick your patient is. Look at their capillary refill and try to assess for signs of heart failure, whether that's peripheral edema, JVD, ascites, those kind of things. If you're called to an unresponsive LVAD patient, try to figure out if it's a VAD problem first or if it's a normal patient problem. Look at their skin color, look at their capillary refill, check all your normal things that you would check on the controller for the LVAD. Try to get a 12 lead, but I wouldn't make that a priority because it's going to be weird at baseline and it's probably not going to tell you very much. 90% of these patients already have a defibrillator, so if it's a shockable problem, they'll likely have already been shocked. So you want to think about other causes, normal causes of unresponsiveness. So check for hypoxia. Make sure you check their sugar. Think about stroke. I can't emphasize this enough. These patients are at super high risk for stroke. And if it's not a problem with their VAD, you need to think about either a head bleed or an ischemic event. One of the most important things you can do, especially if you have extra hands on scene, is to call the LVAD coordinator. These patients get really intensive case management and have immediate access to nurses and to other helpers. So call that coordinator. They know these patients very well. They know their medications. They know how their VADs tend to behave, and they'll be able to help you troubleshoot there on scene. So one of the first things I would do when you're going to a VAD patient is try to find that phone number and get them on the phone as soon as you can. Now, common complications with LVAD patients, usually these are going to happen within the first year. So I try to break it down into three big things. You can have a problem with the pump, you can have a problem with the patient, or you can have a problem with the interface. And if you try to assess those three things separately, you might be able to find out what's going on. So the top 3 causes of death in LVAD patients are going to be infection. So make sure you're looking at that Driveline, assess for fever, ask them about flu-like symptoms or anything like that. Sometimes left-sided heart failure leads to right-sided heart failure, so that's another common cause of death. And then you always, always, always have to think about stroke. So we all know what infection looks like. It is a leading cause of death. Check that site, look for redness, look for pus, ask about fever, think about sepsis, gently resuscitate with fluid if that's the case. One other important thing to think about is bleeding in these patients. Because they do have a mechanical device, they're all anticoagulated for the rest of their life. Now that means that they can bleed, right? You tip the scales in favor of bleeding rather than clotting. They can have GI bleeds, they can have nosebleeds, and they can also bleed into their brain. With the device in their chest that's constantly affecting the flow of blood in the bloodstream, they can acquire von Willebrand syndrome, which is basically just a fragmentation of the proteins that help clot, which again, in addition to them taking the medicine that makes them more prone to bleeding, they're also having an inherent propensity to bleed as well. One of the things that I think is really interesting is that with their chronically low pulse pressure, due to the LVAD, they get this chronic intestinal hypoperfusion. So what that means is that the inner lining of the intestines is not always getting the blood flow that it's used to, and so it tends to slough off. And as that happens, the capillaries tend to kind of degrade, and there's a higher connection between arteries and veins, and that puts veins under sometimes arterial pressure. It's called the arteriovenous malformation. And sometimes those venous walls are too thin to handle the arterial pressures, and they can rupture and cause a massive amount of GI bleeding. And this can happen up into almost 25% of patients. So if you have a VAD patient, ask about GI bleeding. Stroke is a very important thing to consider. They're either at risk of bleeding. Here's what a intracranial hemorrhage looks like, or they're also at risk of clotting, with that blood clotting around the mechanical device, and here's an ischemic stroke here. So if you have an unresponsive or altered patient, you should have stroke high on your differential diagnosis. There's almost a 10% per year risk for stroke, and make sure you're thinking about this in your unconscious patients. It can be difficult to recognize. Usually the risk is highest postoperatively, but this risk is gonna be there for the life of the patient with the LVAD. Pump failure can also occur. Make sure you're assessing power. Make sure you're connecting them to power. And it's okay to actually use a plug rather than their batteries. Everywhere they go, they're under strict instructions to always have batteries with them as backup. But make sure they're plugged in. An important thing to think about in assessing a VAD is a thrombus. So this happens not infrequently. I think it happens less frequently with the newer devices, but still occurs. Here's a picture of a clot. This is actually a fungal infection inside the line there. And then here's just a clot that formed through the VAD device. This is going to cause alarms to go off. You're going to see decreased flows. There might be increased power, what you would expect with a device that's clogged, right? Less flow, more demand for power. So that's going to directly affect cardiac output. So your patients might present with syncope, they might have dysrhythmias, they might feel short of breath, or become a little tachycardic. Another thing to think about with these patients is called the suction event, and that's where they might get a little dehydrated. And remember that the LVAD is actually physically like sucking blood out of the left ventricle to send out through the aorta. Well, if there's less filling here in a dehydrated patient, what can happen is this septum actually gets sucked into the device here and kind of clots it off. And so that can cause arrhythmias, and it can cause alarms to go off in the controller. This is what it looks like on an ultrasound here. On the left, you see the device right here where the LVAD is pulling blood out of the left ventricle, and you can see the septum kind of bowing over towards the device as it's being sucked towards the LVAD. Whereas here, after a little bit of fluid, you see a ventricle that's actually filling normally. The septum is bowed in the opposite direction and not being sucked in anymore. So left heart failure can lead to right heart failure. So this is a pretty common postoperative complication. If you can think about this in your patients, because this can cause them to decompensate. So they might have edema, they might have ascites, there might be some renal failure associated with it. These patients are constantly monitored for their right-sided heart pressures to see if that's developing. Sometimes they'll be on chronic vasodilators or nitric oxide to help relieve some of those right-sided pressures. So we talked about before, LVADs are preload dependent, but if the right side of the heart is starting to fail, then that extra fluid can actually make things worse, and that's called afterload sensitivity. So what happens if you do get that 12 lead and it looks like this? You're going to be tempted to shock it, right? Well, remember we talked about these patients. Most of them are already going to have a defibrillator. And don't forget, like in a normal patient, they're depending on their native heart to pump blood, right? But this patient already has a machine that's doing the work of the heart for them. So sometimes VTAC and VFib, although not great, probably aren't that bad because you have a machine that's already doing the work. So I've actually seen patients that come in VFib with an LVAD, and the cardiologist says just to give them fluid. And so they absolutely need to go to the hospital, but this isn't quite as scary of a scenario as it would be in a patient without a mechanical device in their chest. Most patients are going to tolerate those pretty well. Remember that the LVAD is doing the work. Try to ask them if they have any known right-sided heart failure. If they don't have any right-sided problems, then you can think about fluid. I would do 500 cc boluses at a time. If you need to cardiovert, if they have altered mental status, you can think about cardioversion. Just realize that risk for stroke is pretty high. I would do that in coordination with the LVAD coordinator that you have on the phone. Just realize if you are using electricity for an unstable rhythm in an unstable patient, you're never going to really be able to assess if you got a pulse back or not, because remember, they're in PEA. So you can also think about medications. Again, I would do this in conjunction either with MSEP consortium or the LVAD coordinator. If you have a patient who's in Extremis, just remember as you approach them, work from the outside to the inside. Check that thing for alarms, check the Driveline, listen for the LVAD to be working, and then think about normal patient problems. Now, if you have a patient who is arrested, this is a consensus statement from the American Heart Association, but they recommend not starting chest compressions unless the end tidal is less than 20 in an unresponsive patient that you think is not breathing and obviously won't have a pulse. But only start compressions if the end tidal is less than 20, and that's just because the fear of the compressions will displace and possibly break the LVAD. And that comes from this scientific statement that was published a couple years ago by the American Heart Association. And I actually have that paper if you want to read about it, a little bit more about LVADs. And that's all I have. So if you have any questions, feel free to ask me or reach out to your 7-8.